Welcome to today's AI Plus Health Fireside Chat. My name is Gene Tunik, Director of AI Plus Health at the Institute for Experiential AI and Associate Dean for Research and Innovation at the Bouvet College of Health Sciences, both at Northeastern University. Today's guest is Dr. John Brownstein, Senior Vice President and Chief Innovation Officer at Boston Children's Hospital and Professor of Pediatrics at Harvard Medical School. John, welcome.
Great to be here. Thanks so much, Gene.
John, you hold all of these fascinating roles at Boston Children's and on top of your own research program. Yeah. Can you tell me a little bit about how you got there and what some of those responsibilities are?
Yeah, absolutely. So I've been at Boston Children's now for about 20 years, and it might seem like I'm collecting titles, but there is a method to the madness of where I'm at today. The first 10 years at Boston Children's and Harvard Medical School, I was running a research group, and I still am, around computational epidemiology, this idea of taking large data sets and defining signals from noisy, non-traditional sources like social media and crowdsourced data and data that comes from all sorts of different channels to understand population health. And we use that data to detect potential outbreaks, population behaviors, issues that would go unnoticed without this sort of non-traditional data, which we can talk about. But over the years, we did a lot of really innovative partnerships. We worked with big tech companies like Google and Amazon, but also started recognizing that the innovation that we were bringing to the table led us to building new technologies and potentially new startups and new IP that could go into the commercial setting. And at the time, it wasn't, of course now we talk about accelerators and health systems and academic institutions really spinning off new ventures. That wasn't as popular concept back then. And so given my experience in working with companies, founding companies, I put my hand up to think about building an accelerator at Boston Children's. I became the Chief Innovation Officer, where we started really thinking about the different ways in which we could apply technology to patient care, to optimize the way that we deliver care to all the children that we provide care to at Boston Children's, and recognizing that doing so requires more than just academic research. It requires new innovations, new technology, new partnerships, new ventures. And that's what I've been doing over the last 10 years, is building this accelerator at the hospital, building all this sort of digital health infrastructure that we know are basic now, like telemedicine or remote patient monitoring, also some more forward things like AI and spatial computing, and also being part of a process of really creating new ventures, new startups, taking equity in new companies and investing. So it's a wide portfolio of activities, but it's sort of part of a cohesive theme.
One of the things that's really fascinating that I learned by looking at your profile and in our brief conversation is some of the companies are, such as Uber, for example, right? Yeah. You wouldn't ordinarily think of them as a health enabling entity, right? How do you creatively take these enterprises and figure out savvy ways of enabling healthcare?
Well, our view has always been that it's better to look at what consumers are using in their day-to-day lives and think about how those tools can apply to healthcare rather than having to build things from scratch. Oftentimes, especially in an academic medical center, there's this view that we have to build our own technology, our own social network for patients, or our own tools to support patients. But we want to meet people where they are. And to do so, let's look at what people are using day to day. So Uber is a great example. About 10 years ago, we saw the sort of rapid takeoff of self-assembling logistics and seeing how people can move using an app and on-demand transportation. Then you look at healthcare and you see, well, people are using these outdated taxi vouchers where there's misuse and abuse and really just poor service overall. Why can't we use what consumers are experiencing in their daily lives to help them get to their appointments, get them home from hospitals? Because we know transportation is a limiting factor to people receiving care. So we actually reached out to Uber through actually a support ticket, wrote in, the ride was great, but have you thought about healthcare? And somehow someone on the other side of that that note that we put into a ride recognized an opportunity in healthcare. We met with them, and then we launched a pilot where we were actually delivering vaccines using Uber cars. And that led to a new company where we actually started doing on-demand healthcare transportation using Uber and eventually Lyft. And that's just one example. We've done this many times, like Amazon Alexa. We saw people using Alexa in their home. Well, what about using Alexa as a tool to help log symptoms or to give people health messaging? And we built the first HIPAA-compliant Alexa applications in our system. And the list goes on with OpenAI and with Apple and Google. We've done sort of first of healthcare partnerships, recognizing that might as well go to what people are using and the heavily funded tech companies as a starting point for innovations.
That's brilliant. So on that note, how do you manage risk versus innovation, right? The two are kind of double-edged sword a bit.
No, it's a very good point. I mean, we are definitely pushing the envelope, but we, of course, spend a lot of time thinking about risk. We, of course, have an amazing legal and compliance group at Boston Children's that definitely thinks about risk, and there's plenty of projects that we've tried that have not met the sort of the compliance bar that is required. You can imagine, even in the Uber example, getting to put nurses in cars with needles and moving them around to bring shots to people. That took a long time, and it took a lot of upfront work to getting approval. And so we spend a lot of time with the compliance. We think about risk.
So the Uber was not getting patients to the vaccination sites. It was
the first iteration was actually putting nurses with flu shots in Ubers and mobilizing and getting people immunized at their homes. And so that took a lot of work. We have a group in our own team that thinks about the risks, especially with the advent of AI. Thinks about model transparency and bias, and we're building the infrastructure, of course, to test models to understand drift, which models are favoring which populations, who's being left behind. So it's not just an upfront amount of work; it's also continuous monitoring that is required.
Yeah, and I imagine that some of these projects have shorter runways for success, and others are more mid, long term. How do you balance how to invest in these initiatives given the runway period? It's
really complicated to really fully appreciate, what the time it takes to get these projects going and really at sort of enterprise level. Of course, it's very easy to invest a small amount to get a pilot and show that you could do a one-off. But beyond that, what does it take to fully scale? And so we actually have three parts of our team. We have the source team that's looking for market trends, understanding enterprise priorities. We have the launch team that is thinking about, okay, how do we pilot and quickly get this into the hands of providers or patients? But actually the biggest part of our team is scale. And those are the groups that are working on really implementing these tools, figuring out change management, dealing with the education and bringing people on board. And that is a very long tail. That can take many years before we get hardened technology into our environments. A good example is ambient listening. So this is this idea that you can take the conversations happening between providers and patients and using natural language processing and AI, record that conversation, structure it in a way that then it can be used for documentation purposes. This is very widely popular technology now. We have several partnerships in this space to really get this going. It's very easy to start and have a few physicians that raise their hand and say, let's give this a shot. And this is widely appreciated as like technology that will save people's time, physician time, reduce burnout, improve patient experience. So it meets all of those. But to really get this in scaled with an organization, it takes a lot of time, from the consenting process to the education, the training. This is significant resources, even for technology that is ultimately better for everyone.
Right, and the integration with the other infrastructure systems at the organization.
Exactly.
So you've got all of this stuff going on, from engaging with existing industry partners like Uber and so on, and you've got all of these using existing technology, right? And then you've got all of this in-house stuff that's being built up. You're facing a mountain of data coming in, which is a good thing, but it's still a challenge to overcome. So what do you do with all that data? How do you manage it?
Yeah, well, we do have at one point, it was definitely the Wild West. We have data silos, we have different groups across the institution that are working on their own projects. But the organization actually, a few years ago, and this was ahead of the sort of Gen AI craze, put in a data and analytics steering committee that really was in charge of stewarding data for the organization, putting in the right infrastructure in place, putting in the right analytical tools, and not to sort of be a gatekeeper, but really to be organized, because there, as an academic institution, you can imagine there are many projects, many incredibly well-funded projects, but we're often reinventing the wheel in terms of the tools that we're investing in, the cloud infrastructure we're investing in. And so now as an organization, we have the right stakeholders coming together to make decisions on what that data infrastructure looks like, helping support projects that want to come through the pipeline, and making sure that we're not duplicating effort. And that is fantastic, because not only are we doing a better job of maintaining the integrity and hosting of that data, but now we're also fostering better collaborations, and there's a better understanding of what kind of tools are available to our academic researchers, because there are many, and we're trying to improve the ability to give the tools to people so that they were not sort of double paying or having to do their own sourcing of technologies to support analytics.
Yeah, that's interesting. So as you're collecting all these data from the different sources, do you find that patients in particular are open to giving up access to their data? And are there privacy concerns that you've encountered?
Yeah, I mean, oftentimes, of course, for different projects, we have to consent patients to research projects. There's secondary use of data, of course, from the electronic medical record.
Yep.
We've always found that engagement of patients ultimately is better, because it creates a better channel and an educational opportunity. We run several crowdsourcing projects in our lab, and that they're focused on this idea that, as opposed to making patients just a data feed, making individuals more active in our case, public health. So we run a project called Outbreaks Near Me in partnership with the CDC, where people report in their symptoms and their vaccination status and other elements. And this has given incredible data for us to understand and track emerging infectious diseases, flu, COVID, RSV in the population, understand vaccine effectiveness, understand the value of different interventions. But at the same time, we're engaging people. We say putting the public back in public health, engaging people in the system. They feel part of the fabric of public health, and it creates a two-way channel to educate people about the risks of infectious diseases in their community, what steps they can take to protect themselves and their family. Ultimately, it's sort of better bringing in the patient as a stakeholder.
You're almost enabling them to become citizen scientists and empowering them to be proactive about their own health.
Exactly, and we have found incredible amount of success. We get really high quality data, and it's really informed public health policy at the same time. So it's sort of a win-win-win. Yeah.
You mentioned that there's a lot of noise in the data that you're collecting earlier. How do you deal with that?
Yeah, it's challenging. I mean, especially as we focus in areas, very messy data like social media. That has been, you can imagine the challenges, especially now with some of the changes in some of the social media platforms. And so we've built really high quality algorithms from years of training of data and tagging to build algorithms that support the identification of signals.
You built these in-house?
In-house, yeah, but we've actually fundamentally spent a lot of time working with data curators, so public health trained individuals that are combing through data, tagging things, so nothing replaces a large corpus of heavily trained data that allows us to really inform the machine learning algorithms that we've built. Of course, there's the advent of generative AI, and there's plenty of opportunities to think about not using supervised training sets to build algorithms. But what we have found, and that has worked really well, is a heavily curated training set that is constantly iterating over time.
So right now, it's largely a manual process of labeling and sifting through data.
For for the
supervised,
beginning. And then we have curation and individuals that are looking at the signals, looking at the data, and retagging as necessary, and then we use that information to reapply against our machine learning algorithms. And we do this across many different languages as well. Right. We have language specialists plus public health trained people that are supporting us.
What an operation.
Yeah.
You've mentioned some of the stuff you build in-house, but you also mentioned leveraging existing resources. Yeah. I'm wondering what your view is on, as it relates to transparency, for example, model explainability, building stuff in-house and having relatively full control over the models and the data inputs to those models, and how to infer the outputs, obviously, versus taking existing off-the-shelf models that might be more of a black box.
Yeah. I think it's a trade-off, and in fact, we're running the gamut on both large partnerships and building in-house, and it really depends on the application. So, you can think about all the applications of AI in a health system. They run from obviously the highest risk areas like clinical decision making a decision on a particular patient, on a particular diagnosis based on existing data. But then there's all the back-end administrative work, the emails or the documentation, or maybe the translation services, or post-discharge notes,
the stuff that nobody sees.
Or especially like the revenues and the finance and the HR work. Those are different levels of risk. So when you think about some of the back-end operations, you can imagine it's going to be hard to build some of that stuff internally. There's no special sauce that we have necessarily, and the work of large language models and generative AI makes a ton of sense. So that's where we apply our relationship with, for instance, OpenAI and Microsoft, where we've actually deployed one of the first healthcare-wide availability of ChatGPT. So anybody who works at Boston Children's has a HIPAA-compliant ChatGPT that they can access at any point within our firewall with single sign-on, and they can access ChatGPT 4 and use it for their day-to-day functions, or we, of course, can build them specific applications. And we have many across the board in HR and finance, prototypes in translation, medical education.
Does it include for clinical decision support systems?
You can put clinical data into, it's proprietary information. So especially, and we're monitoring all those applications, and they're about a third administrative, a third clinical, and a third research. You can also imagine all the research applications. Yeah. I'm sure we all use it to help support letter writing and maybe some grant writing, and there's plenty of a good application. We don't have to admit that here today. But there's some, obviously there's the back end of research, there's tons of applications. So partnerships are super helpful there. Even partnerships that rely on understanding all the world's information. For instance, we just are about to launch a partnership with Elsevier. They have a large language model that takes all of the Elsevier content plus other medical literature and uses that to summarize and support understanding, getting the latest and greatest in guidelines and protocols around disease. We're never going to build that, so we have to be able to leverage and understand the ways in which they build these models. But then you look at some of the clinical decision making that is in rare and complex diseases. That's a particular area that Boston Children's is one of the top pediatric hospitals in the world that provides very specific care, to kids where there's really nowhere else for them to go. Well, you can also see the amount of data that we have on rare and complex kids is far greater than probably most places. Then you can see, well, okay, that would be a place where you'd want to build your own models from an explainability and transparency perspective, but also you could never see that in the wild anyways. And so there are many examples where we've built machine learning tools that are specific in disease areas, or for instance in radiology and pathology in specific disease states, or for instance in decision making in the ICU when you want to predict length of stay or predict outcomes based on vital signs that patients have. We have all that historical data. That's where, of course, that level of training and building very specific examples of AI tools in a particular clinical setting, it makes sense for us to build, or at least partner heavily with a vendor in the space.
Is that where you think small language models might have an edge over LLMs, say in these types of instances?
Yeah, I think there's no reason in some cases to take advantage of large language models, the compute, the expense, and the potential for hallucination when you have a very specific decision support. We've actually taken this moment in time, as much as everybody's super excited for generative AI, not every problem has a generative AI solution. But since there's a lot of hype, everybody's willing to rethink how they do their job with new tools. So while generative AI is on one end of the spectrum, there is so much that can be done with just very basic automation, writing a quick Python script that can save someone hours in the day because they've been moving data from one spreadsheet to another. And we see a lot of this. And so we've used this moment to say, okay, bring us your use cases, your ideas, and we will find the right technology to solve your problem. And it may not be generative AI, and that's okay. We use this moment to get people excited, and that's really what matters. And you can the volume of use cases that we're getting are just incredible.
Really? And are these grassroots hey, I'm a physician in this unit at Boston Children's, I have this problem, I need your help to...
So the problems range from very specific, I do this one function, I need help on this very specific thing that I do, and I'm the only one who's doing it. So we will help create a customized response to that, all the way to this is a pain point for the entire organization. We need to figure out how to provide translation services to all our patients. Okay, that's a bigger enterprise level view. Let's understand and source the right vendor or partnership and build something in that space. So it could be small hacks that will build something for you, or okay, this is enterprise level. We may have to build it, but there's very likely going to be an amazing, well-funded venture out there, whether it's large tech company or startup, and we'll work with that company and build a real partnership and deploy a solution against that problem.
Sounds like you guys have created an ecosystem that is really supportive of the soup to nuts stakeholders' needs.
Yeah, I mean, we definitely have a view that we want to build where there's a gap in the market, where we have a unique either data set or view, or there's a specific problem that addresses a real market need, but no one else is going to go after. And we've incubated several startups in that space, and those are well-funded now and really out in the market. But we're also going to be very realistic with ourselves. We're not going to put money towards something that is a problem that clearly there's a lot of venture-backed investment already happening. We will elect a partner. We're not going to try to compete.
Let's talk a little bit about education, AI education in particular. Clearly the landscape's changing. The core competencies are changing. There's a huge need to have physicians and other healthcare professionals entering the workforce with certain literacies in AI.
Yep.
How is Boston Children's and Harvard Med School, for that matter, approaching that?
Well, we've done a lot of work to build a curriculum in AI for our physicians and actually all our employees. We actually are constantly building this, sort of set of training materials that we're rounding with to every department, every group, and explaining, of course, the basic principles of AI. What does generative AI mean? What is the spectrum of AI tools out there? What tools are we making available? How to deploy those tools responsibly, fairly, making sure people recognize that they're responsible for the technology that they're using. This is not AI in the wild. Ultimately, if you're going to use a tool, you're going to be responsible for the output of it. So you have to make sure...
The accountability is on the clinician.
The accountability, depending on the application. We make sure that accountability is recognized. Even if you're using AI as a co-pilot, you're still responsible for it. And so we've built a bunch of training material. And we're out there, supporting physicians. We're also building tools to train health systems outside of our own organization because, we feel very privileged that we have a lot of resource to build up some of this stuff. So, of course, we want to deploy it just beyond the walls of our hospital.
How's the American Medical Association and other accreditation, clinical accreditation bodies handling this? I mean, is there everybody does it their own way, or is there some sort of a unified common denominator?
Yeah, there is many groups that are organizing. Of course, you can imagine every health system is, and all providers are grappling with some of these same topics. So there's a number of networks that have formed over the last couple of years. Coalition for Health AI, for instance. They're building basic principles and supporting organizations in deployment and validation of AI tools. There is a number of other networks that have emerged. Valid AI is one example, which is really a network of health systems all sort of sharing basic learnings. So we're all trying to view this as all ships rising. If we can all sort of support each other, share best practices, share the best vendors that are supporting different organizations, and share training materials, that's what's happening. It's happening somewhat organically and then more officially through some of these nonprofits that are emerging right now.
So if I could put you on the spot a little bit, what do you think should be the core competencies on the clinical side for individuals using AI for clinical practice, not for office operations, but in decision support systems or related? What level should they be at in terms of their literacies in AI?
Well, I think if anybody's going to be using these tools, especially large language models, they have to understand how they're generating this information and how a large language model is built and how much to rely and not rely on the information and be able to, of course, verify sources and make sure that they're checking the output of these models. Do they have to have a full sort of understanding of how a large language model is built, soup to nuts? Probably not, but you have to have a basic understanding of what these models can produce and how much you can rely on them. And at the end of the day, it's all about responsibility, accountability, and it also depends on the tool. There's going to be a wide range of tools that clinicians are going to have access to in the coming years. I mentioned, of course, ambient documentation. There's also going to be a series of tools that are going to create support email messaging, and in basket, those are already being deployed in healthcare, where your physician is not really writing the email, they're just approving an email that a large language model wrote on behalf of you to then send to the patient. It's going to reduce a lot of time and frustration at the same time that you're going to have to take some time to understand and check and verify that what you're sending out to patients is correct. And then, of course, the holy grail is going to be the clinical decision making. And we're going to inch and move into that space very carefully. And that's going to require a deep level of training on the part of clinicians, because you don't want the practice of medicine to be completely just reliant on these tools and relegate the clinician, of course, to just sort of a data entry person. And of course, this is going to be a sort of a collaboration between man and machine. So that's really how we need to figure this out. And also, of course, we're building medical training tools based on large language models right now. We've actually built a tool to allow for a trainee, a resident or student to interface with a large language model to help do a differential diagnosis on a patient. And these are incredible training tools because they're interactive, there are unlimited numbers of cases, they allow for better evaluation. And so the ability to use these tools not only for the medical decision making but for the training is what we're especially excited for.
Yeah, I think that's an enormous opportunity on the education side. So you mentioned something interesting, that the AI tools, it's going to be a physician AI tool collaboration. And I've heard different viewpoints on that, where on the one hand, it's sort of an extra member of the healthcare team. At the other end of the extreme, it's more of a support system, if you will, for the physician, who is the only member of the or the clinician. So, looking ahead, 3-5 years, 7-8 years, where does AI sit in your view in that relationship?
Well, I think it's maybe semantics to say whether the AI tool is a member of the team or just a supportive element. At the end of the day, it's still going to be the clinician who's going to be ultimately responsible. But as a patient, you can imagine, like, how could you not want your provider accessing all the most recent, best-in-class science? There is no possibility that you have a physician that already has all that information at their fingertips. And frankly, they were already using these tools. If you look at UpToDate and other tools, they will use those to their advantage, and they should be using those. So, the view is, of course, we want to bring the latest and greatest to optimize the clinician. But at the end of the day, we have to be very clear that in the next 5 to 7 years, this is not just about these large language models outputting. It has to be a coordinated integration between these tools, medical data, because there's not, that integration doesn't exist quite yet. It's happening in some research projects or some one-offs, but being able to pull, the vast amount of your data alongside, data from the entire population of people that look like you, plus the best-in-class medical knowledge, that is going to be, optimizing care, at the greatest. And of course, now we think about not just the care that we can receive in the best, probably medical city in the world, Boston, but you think about the democratization of that content, the idea that all that know-how and that data and insight can then be used to help support decision-making across the globe, where you may not have that same level of specialization.
So, coming back to the 3 to 5 year runway, looking ahead, relatively short term, right? What do you think is the most exciting, most likely to succeed AI application on the clinical side again? Is it language models? Is it some sort of a real-time predictive AI using data collected in semi-real time? Something else?
Well, I think we've already, I think what people often forget is AI has been part of the practice of medicine, for the last decade. We're using these tools already to support, from the beginning part of a patient's healthcare journey with symptom checkers, to supporting them when they reach the ED and supporting triage, to helping, obviously clinicians right now in the documentation process. So there is plenty of examples of that already happening. I think sometimes we forget that was a AI journey ahead of generative AI. I do believe that the physician time spent in the outside activities of beyond patient care are going to start to shrink. And that is going to hopefully bring back more of the joy in the practice of healthcare. That's what we hope. And we've seen this already with some of the small even tools and improvements. We see physicians getting to spend more time with their family, not, we call pajama time, like spending time in the documentation after hours because they haven't been able to get through everything. So that reduced burnout will translate to sort of better practice, better patient experience ultimately. And we're going to see sort of some similar advances on the patient side. There's going to be the ability to, of course, collect better data. We all have our wearables and data, and we're seeing improvements on that side. And the taking of that data, the processing it with algorithms, the more continuous ability to view a patient over time rather than episodic, once a year or a few times a year. That's going to bring a lot more joy back to people and their experience with the healthcare system as well. And so I actually am very optimistic for how our health systems are moving. And there's going to be, hopefully, because of some of the availability of these AI tools, also sort of an overall reduction in the spend related to healthcare. We're not saying that we're going to reduce our workforce, but we may not see the same level of growth of the workforce and the spend and the administrative costs of running health systems over time because of these tools as well.
Yeah, I could see that playing out. With all the optimism, what gives you most pause?
Well, I think that we have to be incredibly careful as we deploy these tools. So I'm in public health. So I see how you can have major pushback over things as simple as masking, or we had a very effective vaccine, and people looked at that vaccine like it was really, a government plan to wire our brains.
Conspiracy theory. Yeah.
They're everything, and we've dealt with all of it, and especially look at vaccine confidence. There's one rumor about a vaccine, confidence can drop, and people reject it. So you look at what happens in public health. And then you look at AI, and people are still skeptical. There's a lot of concern about AI. We've done some surveys, and we've seen, about a third of the population is ready for AI-based primary care, which is exciting, but 2/3 are still not ready.
Yeah.
So imagine what happens when we have an adverse event related to AI, and something goes off the rails, and there's a safety event or an unfortunate death as a result of an AI algorithm.
That kind of pulls the rug from...
that's going to create a real pushback, and all this progress is going to come unwind, and there's going to be major regulatory changes, and there won't be as much of an excitement to bring AI to the bedside. So that will happen, but I think as a health system, as people deploying these tools, we have to be ultra careful to try to avoid that major pushback, and so that's what gives me pause.
Yeah. So slow and steady wins the race.
Slow and steady.
Yeah. One final question for you pertaining to research now. Tell us about how your research in AI has informed clinical practice at the hospital.
So it's actually interesting because Boston Children's had one of the most challenging moments in taking care of patients last year. This was at the tail end of the pandemic, but in pediatrics, there was a real challenge in the fact that we had what was called the triple-demic, the COVID plus flu plus RSV, and not just those three viruses, a wide range of respiratory viruses cycling in the pediatric population, which led to a real capacity challenge in the hospital. There was an inability to take care of all the patients, in addition to all the elective procedures that we want to manage for our population. But at the same time, my research group focuses on infectious disease surveillance. We think about new data sources, we think about new methods, machine learning tools to make forecasts about what may take place. So this was a really interesting merger of both the research group and the hospital operational side. On the research side, we were able to build algorithms that predicted flu, COVID, RSV, all simultaneously, as well as looking at, for instance, our behavioral health crisis and making predictions on what patient volume might look like as a result of looking at the waves of infection taking place around the country. So we can watch how different viruses are spreading across different parts of the country and make predictions about what we might see here in Boston. So we took those algorithms and actually integrated them into a capacity infrastructure that was actually making specific predictions on bed availability within the hospital. We implemented that into practice, and then we were able to essentially identify when we might see relief from these circulating public health threats to then start to bring back elective procedures. And we were effectively able to predict flu, RSV, and COVID within days of their turning, that ultimately was able to mean that we could see more patients. And so what's interesting is, there is this linkage between public health and healthcare delivery that oftentimes, these things are happening in silos, but of course, the pandemic really highlighted the fact that the more that we can bring in our public health research, it's not just about health systems providing data for surveillance, but that surveillance data and the models that result can inform healthcare delivery as well.
That's an absolutely terrific example of how, because there were major backlogs in elective procedures for months and months. And so the ability to leverage the pandemic data and the prediction from your models to keep the ship going forward, I mean, that's tremendous. John, thank you so much for joining us today for the AI Plus Health Fireside Chat. I really enjoyed learning about everything that Boston Children's is doing.
Thanks so much, Gene. It was such a pleasure to be here with you today.
Thank you for joining us today. If you're interested in learning more about AI Plus Health, please visit our website.